Good evening. Shyam sir, am I audible, sir?
Yes, Prasad, you are audible and visible.
Thanks for the introduction, sir. Thanks for this opportunity. Since this COVID situation started, I have been seeing, I've been a part of many webinars with Shyam sir. And I should appreciate that the flowers near this is the corner you choose every time for your webinar, and they are always fresh, sir. I appreciate that. So we will go ahead with this ESMO guidelines update on gastric cancer. And this is an Eli Lilly sponsored session. I have been contracted by Eli Lilly for this. This is my disclaimer. So we will go, this will take maybe 10 minutes time. So this is about updation of the guidelines from 2016, 19 and presently, which is interesting how medical oncology treatment in advances and how we one treatment which was the standard of care sometime becomes a non-acceptable standard of care with time. That is how science advances. So if you take the 2016 Annals of Oncology update, the ESMO guidelines management, the first line treatment, doublet or triplet was accepted standard of care with the DCF and FLOT regime, which we all used for a lot of patients in first line. And then the second line there also was the standard of care was to give ramucirumab with paclitaxel based on the studies which we all know about either single agent ramucirumab in unfit patients and in combination with paclitaxel. Similar efficacy was seen for single agent if you are only choosing chemotherapy, paclitaxel and irinotecan. Those were the second line treatment options. And trastuzumab, the data of trastuzumab in HER2 positive was just coming, and that was also approved as a personalized medicine and targeted therapy. Then when you see, so if you see the publication in 2016, this was the flow chart. The palliative chemotherapy, either giving a combination of a FLOT or a DCF kind of protocol, or in HER2 positive breast cancer, giving the CF with trastuzumab. And second line therapy was the paclitaxel ramucirumab, or in MSI high patients, the pembrolizumab. So then in this is again a continuation of the same in Lancet 2020, when still we didn't have much updation in terms of the first line therapy. So what has happened, or the new publication which came in 2022, few things we all know about the trials which actually came in first line metastatic gastric cancer with immunotherapy coming in. And now we are looking at more options for patients with first line therapy. So the HER2 status, we all do that now. It is almost a standard of care to check the HER2 status in all patients with gastric cancer. And now with the present data of the pembrolizumab as well as nivolumab data, the PD-L1 CPS score should be evaluated in patients with metastatic gastric cancer to tailor first line therapy. This is based on the randomized trials of nivolumab and pembrolizumab in this group of patients. So first line chemotherapy, if you the recommended therapy now is a doublet chemotherapy. Platinum with fluoropyrimidine is recommended. And specifically, if you see what I said in the beginning was that the standard of care becomes changed. So due to higher level of toxicity and uncertain survival benefit, a first-line taxane-based triplet therapy is no longer recommended as a standard approach. That is the present guideline clearly says that a triplet chemotherapy is not to be considered in first-line metastatic gastric cancer. And trastuzumab chemotherapy is recommended in patients with HER2 positive cancer. And the other two drugs, the nivolumab chemotherapy. This is based on the randomized trial, which proved that in patients who have PD-L1 CPS score more than 5 with untreated gastric, esophagogastric junction and esophageal cancer, there is an improvement in survival by adding nivolumab to chemotherapy. Similarly, for advanced gastric cancer of esophagus and esophagogastric cancer patients expressing PD-L1 CPS score more than 10%, pembrolizumab is also approved. So the new flow chart doesn't have a triplet chemotherapy as an option, or it is considered as it's a wrong treatment to choose if you want to give a triplet chemotherapy in the present scenario. Test the patient for HER2/neu. Add a triplet combination, can be either an immunotherapy combination or a targeted therapy with HER2/neu in patients who qualify for that. So in HER2 positive patients, the addition of trastuzumab with high recommendation, and in PDL1 CPS score more than 5 patients, the addition of nivolumab. There is also a mention of radical resection in highly selected cases. These will be patients maybe who present with obstruction or bleeding, and mostly we don't have patients with advanced gastric cancer who go for radical resection. So what is the scene in the second line? This is something we all know, that most of the patients with metastatic gastric cancer will progress. And with the present regimes, I think we can say that we can get a first line patient getting a PFS of something close to 9 to 12 months with the present first line therapy options that we have. But most of these patients progress. And with the data of post-progression immunotherapy, we don't have strong data. But the present recommendation with what we have is that still the second line option is ramucirumab paclitaxel as a standard of care, and ramucirumab monotherapy in those patients who cannot take chemotherapy because of some reason. If ramucirumab is not available or the patient cannot afford, which is a scenario in our country, irinotecan, paclitaxel, docetaxel, or even FOLFIRI, if the patient is fit, can be our recommended therapies. We all use these chemotherapy options. So keeping the taxane for the second line, regardless of whether the patient is going for ramucirumab, is a good option, because that helps us to prolong the PFS of the patients, and like that the overall survival as well. And MSI and MMR status should be assessed for patients with advanced metastatic gastric cancer to tailor treatment accordingly. So second line therapy options, if there is no contraindication for chemotherapy or anti-angiogenic therapy, the treatment recommendation is ramucirumab and paclitaxel. If there is contraindication for chemotherapy, then ramucirumab monotherapy is approved therapy and is recommended. If there is a contraindication for anti-angiogenic therapy, then a single agent taxane or irinotecan, most of us use on a weekly basis for many patients, which is accepted standard of care. And if the patient has an MSI high, pembrolizumab monotherapy. So this is the recommendation in second line patients. And with the data on trifluridine which we have some access now, we have this also coming in for patients previously treated with 2 lines of therapy. So we have a third line approved option, which is trifluridine now. Alternative therapy could be a patient who has not received a taxane or irinotecan. It can be considered as an alternative therapy. So in third line, the approved treatment is chemotherapy. This will definitely change when more patients will get first line immunotherapy, chemotherapy combination. I'm sure that we will all have patients very soon who will be progressing on these protocols, and we will be waiting for the long-term data to see what is the best second line, third line options in patients who receive immunotherapy in their first line. So as per the present guidelines, the third line therapy option is chemotherapy, oral therapy if it is possible, or IV therapy is preferred with taxane or irinotecan, and trifluridine is also approved in this scenario. So this is the last slide, I think. In summary, HER2 status and PDL1 CPS, it has changed in the last decade. I would say that the treatment of first line metastatic gastric cancer has changed because of these 2 data which we have. All the patients should be evaluated in metastatic gastric cancer to tailor the first line therapy in combination with chemotherapy. MSI should be assessed for second line therapy. So most of us, we do it in the first line to have the data with us. Doublet chemotherapy is first line standard of care, and all the guidelines now clearly mention that a triple chemotherapy like FOT or DCF is not recommended in first line. Immunotherapy plus chemotherapy is definitely the standard of care for first line PDL1 positive patients. FLOT is no longer recommended as a standard approach. We still use in some scenarios, but it is not recommended as a standard approach due to specific reason. And ramucirumab paclitaxel is still holding the second line recommended treatment option when the patient can tolerate both chemotherapy and anti-angiogenic therapy. When ramucirumab is not available or not affordable, or there are other contraindications for anti-angiogenic therapy, a single agent chemotherapy with paclitaxel, docetaxel, or irinotecan, or a combination of chemotherapy is recommended. That's all from my side. Thanks a lot for patient.
Thank you, Dr. Prasad. Just to seek a clarification. So I think these slides and recommendations are meant for patients with metastatic or advanced gastric cancer.
Yes, sir.
So FLOT is still good for patients who have resectable gastric cancer in the neoadjuvant setting.
Yes, sir. So resectable gastric cancer is a standard of care because we can afford to have we'll agree to the toxicity in those patients where we are going for a curative intent therapy.
Right.
In continuity to this, can I ask a question, Dr. Shyam sir?
Yeah, Naresh.
So we assess that the patient is locally advanced. So we give the FLOT and then we try to operate, and patient remains inoperable or the peritoneal mets are there. So in a responding patient, tolerating patient, in this scenario, will you continue FLOT or you will try to change to the lesser toxic regime like the Folfox or Capox?
So you mean to say the patient had a response in the scan. We went in for resection and found it is metastatic disease.
Yeah.
In such if this is a scenario, I would continue the treatment which the patient responded to. Sir, I will not now go down on this patient.
That's a common scenario. Yeah. Yes, sir.
Yeah, if the patient is tolerating, I mean, why to change the therapy? If the patient is not, I mean, we understand that this patient is having incurable illness because of the peritoneal metastasis, so which were not seen at the time of CT scan or PET scan before starting FLOT, which were only visible on the operation table. So that does change the stage to an advanced disease.
Sir, there are the two questions in the chat box. One question is similar, almost similar by Dr. Vineet Talwar and me. Dr. Prasad, would you like to answer?
So Dr. Prasad is there. So Prasad, do you use pembrolizumab in first line for an MSI high?
Sir, I'm still getting used to the immunotherapy in first line. A couple of patients only nivolumab I have not used pembro first line actually.
No, if the patient is MSI high in the first line.
MSI high.
Yes, you're talking about MSI high. That is the question of Dr. Naresh.
I very recently had a patient. PDL1 is not supporting the use of the IO, whether it's the pembro or whether it's the nivo. But the patient's this MMR turned out to be the deficient with the two markers, PMS2 and something like that. So I try to continue with the because of the Folfox, I try to continue with the nivo being the 2 weekly schedule. But if I use the Capox, then I would like to add the pembro.
First line single agent pembrolizumab in metastatic gastric cancer. I don't know how many of us have actually given.
No, not single agent. Yeah. Along with the chemo.
No, to answer that question in chat box actually, yes. Along with chemo, fine, because we all want that response actually.
So single agent IO based on the MSI is there in the other malignancies.
Yes. Yes, sir. Agreed.
No, Prasad also showed in the second line that if MSI is high, then pembro can be used as a single agent.
Right.
So the question is only in the first line whether you can do it alone or in combination with a Folfox-like regimen.
Second line MSI high based IO is there. I think it's a blanket approach.
Right.
Anywhere if the
Vineet, your call.
So the first line, even if the MSI is high, I have seen it in a couple of my patients. If we gave a single agent because the general condition was not good, the behavior is not like that of what it is seen in lung. The response rates are abysmally low, and invariably after 3 or 4 months they relapse. So, as Prasad said, that if you give it in conjunction with chemo, probably that would be the best bet.
So Dr. Vineet, when based on the PDL1, you can use it in the first line along with the chemo. Based on the MSI, why not to use with the chemo in the first line?
See, logic does not play a role. There are so many other situations which all of us can quote that in phase 2 it worked like magic, and when it came to phase 3 it flopped miserably.
So PDL1 positivity is a marker of the positive predictive value or a marker of the negative predictive value? If the PDL1 is negative.
See, you can chew the data whichever way you want, but at the end of the day, if you have a trial and you can prove it, Probably that's what it works. So
So
my
I think
question,
yeah. So I
my
think the
question-
bottom line, and I think let me just also state this for the sake of clarity, that this data holds for adenocarcinoma, whatever was presented. So it is not for esophageal squamous cell carcinoma. So GE junction adenocarcinoma or stomach adenocarcinoma, I think Prasad presented the data here for that. So I think it has become prudent now on the part of oncologists to not only do the HER2/neu testing, but also to include CPS scoring on the tissue so as to decide in the first line for using either HER2/neu inhibitors or using the IO drugs, depending upon the CPS. And I think both have a level 1 evidence, as was shown in the slides. So I think the practice is evolving, many drugs becoming available. So if somebody has CPS more than 5 and HER2/neu 3+ as well, so then I think HER2/neu will take precedence over the IO drug. Prasad?
Yes, sir. Agreed. Agreed, sir.
Right. So I think we have a fair amount of consensus here today. And of course, a second line does not get altered. Whatever you use in the first line, ramucirumab with paclitaxel remains the second line treatment, irrespective of the CPS or HER2/neu, etc. So I think third
May
line.
I add something here?
Yeah.
You've given Folfox and Nivo. You have a CPS of more than 5 in first line. Patient progresses. And then fortunately or unfortunately, you check the MSI, it is high. So re-challenge of IO, single agent. Now what do you say?
Second line, it is approved.
That was your question.
Yes, second line, it's an approved standard of care. If the MSI is high in second line, we can use pembrolizumab single agent.
But Prasad, you have already exposed to one IO.
Agree, sir. But the data, I mean, as of now, we don't. That's what I said, that when we have more patients, more prolonged data on the patients who progressed on Nivo plus chemo combination, whether they will respond to a single agent immunotherapy is questionable, but it's an approved therapy.
Fine.
Yeah, so it's I know it's tough, Vineet. You're putting everyone into a corner because there may not be, I mean, this can be applicable to other malignancies also, where in first line Nivo or Atezo are approved, and then you find the MSI to be high. So should this patient be re-challenged with a drug like Pembro, or should you give, for example, in stomach cancer, still hold on to ramucirumab in the second line by a few months before you re-challenge with pembrolizumab? So, those will be important discussion points. But I think we need to use all the agents in metastatic disease to sort of in a sequential fashion to give the best to our patients.
Probably in the third line we can place it.
Right. So I mean, I think options are definitely open. You may not have the answers right now ready, but I think again, for patients who have been exposed to an IO before, a doublet of IO is also shown to be effective in so many trials. For example, in RCC, when Pembro and Exi fails, a doublet has given some positive data only in the phase 2 settings. So I think here you are reversing the drug scenario, Pembro followed by Nivo before. So I think these are sort of issues which will perhaps remain for a while until we have more data in this direction.
Thank you, sir.
Thank you, sir.
Right. So I think with this.